Okay, everyone. So how are you with us?
Yes, I am.
Great. Okay. So why don't we go on and talk about trauma now? Let's see, who had the last case?
Tom.
I already forgot. Okay, Tom. Okay, there you go. Sam?
7-year-old quadriplegic through a car accident. Let's see, 3-4. There's a lot of signal in the bones and the vertebral bodies, and some disc, either extrusion or protrusion there at that level, and a lot of cord compression with high signal. So yeah, a lot of
cord compression, acute cord compression from an acute disc herniation on the cord from trauma. So that's these are typically considered emergencies. Some people have described that some of the function may come back if you operate and decompress it right away. Most of my experiences with this, however, is that unfortunately you often don't get a lot coming back.
Okay, 62-year-old woman. Okay, on the GRE, it looks like there's sort of transversely oriented signal within the cord at the thoracic level there.
Yeah, so I don't always wonder if there could be artifact there.
Yeah.
Axial images. We kind of blow it up, we can see.
Is there some high signal in there?
So, actually, it's what it is. Low signal around the side. This is superficial cirrhosis. And it's hemocytic deposition from chronic subarachnoid hemorrhage. So it's really really kind of hard to see this, and it's very subtle. This actually was a case that was proven, but it's very difficult to see. But this is someone who did have chronic subarachnoid hemorrhage with some hemocytic deposition, but I wouldn't call this on MR.
Okay, so 17-year male, right hand weakness for a year. Okay, so axial and sagittal. Okay, so in the there is extensive epidural, right, hemorrhage probably.
So this is runs for a year. I wish the dates are not here. I lose some tissue thickening back there.
Right.
This is really good usually about the dates.
So is hemorrhage versus hemocytic deposition.
It's a 1 year. I think he said symptoms for a year.
It's symptoms for a year.
And before that was the acute. He went back.
What?
I think before this was the. Wasn't there an image before this?
No, this is the first one. So, yeah, I think this is the current time. This is a year out. I believe this is a study from a year ago, but I'm not 100% certain.
So extensive epidural traumatic hemorrhage probably.
You can see the thickening there. This makes sense. No, I don't think this goes with it.
No.
I'm sorry about this. I don't have the details. I think this is a different case. Sorry. So anyway, so they thought that was Verona disease, which gives focal atrophy right in through this area, right in through here. And it's typically in the around C5 and below. And it's just in young kids that have very flexible spines. And it's thought to be due to repetitive trauma from the cord in a hyper mobile spine in young kids. That's a subarachnoid hemorrhage. And then you can get focal myopathy from this, and it's basically motor neuron disease. And the MR scan is generally pretty normal, except you just see some subtle atrophy right where the cord is supposed to be thickest. And it's thought to be due to hypermobility of the cord, but other people, there's still some debate about this. First described in Japan. And the differential are the typical differential that you have in motor neuron disease. So I guess this is the same case. And what they found is that when they put them in flexion, that you had increased space posteriorly.
So those are dilated veins posteriorly.
Those are dilated veins. All right, Sahara.
19-year-old male, progressive right arm weakness, hyposthesia, onset 5 months ago, right arm muscular atrophy. Okay. Is it showing the force? Okay. We have some reversal of the cervical rhodosis, multi-level disc disease. It seems that there is some atrophy of the spinal cord, in the mid to lower cervical spine.
Right.
So chronic. Now on the flexions, is it a posterior epidural collection?
Yeah, it looks like there's again this widening posteriorly, atrophy of the cord right in this C5 through C7 level. And this was another case of disease.
That's venous structures, you said, dilated?
Yeah, I think so.
How could that possibly?
I think is what you do. I think this is debated, but I think what happens is you have hypermobile spine, you get trauma to the cord, you get atrophy of the cord, and then in the flexion position, since the cord is atrophic, the increased space posteriorly is filled in by dilation of the veins. Yeah. Yeah, there are some people who believe that maybe the veins are there, they compress the cord, but it's just in young people who have hyper mobile spine, so I think it's really the trauma is the cause of it. And it also is in the teenage years during growth. Here's atrophy.
You can't reverse it, I guess, right? You just...
I do not believe it's very well. Actually, I thought I don't know. I don't think much of it is reversible.
Yeah.
But I've never actually diagnosed a case myself, so I haven't seen it. Okay, here are just some other examples showing the atrophy right where the cord should be widest, with increased space in the venous. And that looks normal when you go back to the normal position. So if you're concerned about it, people believe that you should reposition the neck in flexion and rescan in the sagittal plane to see this. And I don't know if they've actually done studies to see how frequently you can see dilation of the venous plexus dorsally in normals. It would be interesting to see. But I haven't really reviewed the literature in depth on this particular disease, since I just haven't seen very much. I haven't seen it. Okay. And then if we actually look at, if you look at myelopathy and changes within the cord, there are different ways to kind of describe them. This is really more, I think, for research purposes, but you can have a kind of a diffuse central signal abnormality, fuzzy bilateral, or more discrete bilateral. This, as we saw before, it can be the owl's eye appearance that you can typically see in ischemic disease, whereas the diffuse is more of an inflammatory or tumor type. and it has the worst prognosis. Okay, well, I think we're finished with the cervical.
Sorry, what do you see type 3 in?
What?
What do you see type 3 in?
It's chronic long-standing.